Hi, my name is Dr. Esther Chang. I'm an ophthalmologist here at Wilmer, and I'm very excited to be teaching about the eye exam. Today we're going to learn how to measure visual acuity, how to look at the pupils, and how to look at the front and the back of the eye. Let's go in. Hi, I'm Dr. Chang. How are you?
I'm good. How are you?
Good. I'm just washing my hands real quick. Good to meet you.
I'm Neva Kraus.
Good to meet you, Ms. Kraus. The first part of the exam is measuring the patient's visual acuity. And you always want to do this before you start shining any lights into the eyes, because bright lights can blind patients and can make it harder for them to read anything. You measure the visual acuity using the Snellen card, which fits nicely in your white coat pocket. You have the patient. Mrs. Kraus, I'm going to measure how well you're seeing now.
Okay.
You have the patient hold the card at a comfortable reading distance. People typically say 12 to 14 inches, but it really doesn't matter, whatever is comfortable for them. Before you start asking them to read, it's very important to ask them, Mrs. Kraus, do you wear glasses to read at all?
I do, yes.
Do you have them with you?
Yes.
Could you put them on, please?
Sure.
Thank you.
Mm-hmm.
You'd be surprised how often people forget that. So you want to test visual acuity one eye at a time. It's possible to ask the patient to cover their eye themselves, but very often their hand slips or it's easy for them to peek. So a nice way to do this is if you have tissues in the room, just take a tissue. I'm going to cover your left eye now so we can see how well your right eye sees.
Okay.
I'm just going to slip these tissues behind your glasses.
Okay.
If you can close your eyes,
Mm-hmm.
you just slip it like that. Make sure it covers their glasses. And you can open your eyes now.
Okay.
And hold it at a comfortable reading distance.
Mm-hmm.
And you ask them to read the smallest line of numbers on the left-handed side of the card that they can comfortably read. Can you do that for me? Read the smallest line you can read.
374258.
And then you want to ask them to, if they can read the smallest line below that, always push them as much as you can. It can help to hold your finger to show them which line it is. Can you read this line
Mm-hmm.
below that?
I can try.
Sure, go for it. Guessing is okay.
987628.
Okay, great. Thank you.
Mm-hmm.
Let me take this tissue out now.
Thank you.
So when you're measuring how much they can read, they're allowed to miss 2 numbers on a line. If they miss more than that, then you should count the number above it. The way you record it is by looking all the way across to the right-hand side. It's recorded as a number that is 20 over something. In this case, she read 20 over 30. So then we do the same thing for the other eye. Could you hold this card again?
Sure.
I'm going to move this tissue over to your other eye. You close your eyes for a moment. Good. And you can now open your eyes. And hold it at a comfortable reading distance. And again, can you read the smallest line of numbers on the left-hand side of the card?
374258.
Great, good job. How about this one? Can you give this one a try?
Okay. 967426.
Very good. You got all the numbers there. I'm going to ask you to read this smallest line here right above my finger. Just do your best.
Okay. 423786.
Great. Thank you very much. Encouragement is good because often people feel like it's a failure in some ways. They can't read the numbers. And that's it. The next part of the exam is taking a look at the patient's pupils. You'll be learning about this in the neurology section, but I'd like to show you how ophthalmologists like to approach this. So first thing is to find a light source. Any kind of pinpoint light source is fine. Anything from the wall or a flashlight or a pen light from your white coat pocket is fine. The first thing you want to remember when looking at a patient's pupils is to have the room as dark as possible and your light as bright as possible. This will make the biggest difference between a dilated pupil, which is dilated in the dark, and a constricted pupil, which constricts to bright light. So first find a switch where you can turn the light dimmer. Then make sure that if you have a light, you've adjusted it. Often it's with these this turnable part of the handle until it's as bright as you can make it. Then you have the patient sit at about your face level and have them look straight ahead towards as far back to the room as they can. If they look too close, sometimes they can accommodate and that will make their pupil a little bit larger. So just have them look. Could you look, Mrs. Kraus, as far back? Just find a point on the wall and just keep looking there. I'm going to shine this bright light back and forth between your eyes and I'm just checking your pupils. When you begin, you want to shine the light in the same direction and angle in both eyes, and you want to leave the light on each eye for the same amount of time, typically a few seconds. What you should see as a normal response is an initial rapid constriction followed by a slow period of dilation. If you leave the light on for too long, you'll eventually see it dilate. So you want to move about this rate. I'm going to shine this light back and forth now. Keep gazing to the back of the room. Initial constriction, brief dilation. Initial constriction, brief dilation. That's what a normal pupillary response should be. You may notice in some of your patients, particularly if they're older and have had eye surgery, their pupils may be irregular in shape, and just note that in your exam. The next part of the exam involves inspecting the front of the patient's eyes. For this, you'll want to turn the room lights back on and keep whatever light source you had. It's important to remember that the front part of the eye involves more than what you can just see with the eyelids in their natural position. So you'll have to pull on the eyelids a bit and have the patient look around in different directions. Typically what you're looking for is that the white part of the eye is white and it's not jaundiced or yellowish and it's not red from conjunctivitis. So what I'll do is, Mrs. Krause, I'm going to take a look at the front of your eyes now. If you can look straight ahead for now. Position your finger about such with your left hand for her right eye to avoid bumping into her nose. Can you look all the way up? And again, you focus on the white part of the eye below the pupil, but you also can look at the inside of the eyelid. You may see some discharge, you may see some redness if the eye is inflamed. Typically the jaundice is easier to see in the white portion of the eye, but be sure to inspect the inside of the lids as well. Can you look over to your right? Look over to your left? Good, and can you look down? Wonderful. We're going to take a look at the other eye now. The last and frequently most challenging part of the eye exam is taking a look at the back of the eye, which we call the fundus. This is called the fundoscopic examination. To do this, you want to turn the room lights down so they're a little bit dimmer, and that's because that makes the pupils dilate and gives you a larger window to look through. You want to exchange your hand light for a direct ophthalmoscope. Most of the time these are set right on the wall, but you can also carry a portable one in your pocket if it's easier. Let's take a brief look at the ophthalmoscope and what the settings are on it. There's a dial in the front that just controls whether the light is green, whether it's white, or whether it has some crosshairs on it. You can use a light with crosshairs if you want to be able to localize things better, but I usually just use the light that's white because it's straightforward. You'll see a number here, and that reflects the refractive correction built into the ophthalmoscope, and the dials on the side control that. The easiest way to do this is just to set it at 0 and look through at something, perhaps your finger, and dial it from side to side until you find one that's clear for you. If you are wearing glasses or contact lenses, then you can simply set it to 0, which should make everything clear, which means no refractive correction in the scope. The dial on the handle will adjust how bright the light is, and typically you want to have it at its brightest setting. When you're doing the exam, for the right eye, you want to be standing to the patient's right, and you want to be holding the ophthalmoscope in your right hand, and you want to be bracing your left hand against the patient's shoulder or against their forehead. This gives you a sense of how close you're getting to the patient. For this exam, you'll be getting very, very close. Your forehead may even be touching your finger on their forehead, so don't be afraid to get very close. When you start off, you'll start off about a foot away. You'll shine the light into their eyes until you get a pupillary light reflex. That just tells you you're shining the light into the right direction. Then you'll inch closer, keeping your light trained on the pupil until you can start looking through it and seeing the back of the eye. Typically you'll see something that's pink, that's just the background retina, but try to look for a blood vessel. All blood vessels lead to the nerve, so follow the blood vessels in until you see the optic nerve. The optic nerve is actually located a few degrees nasal to where the straight ahead back of the eye is, so you'll be actually angling your view a little bit nasally to see the nerve. For this part of the exam, it's absolutely wonderful if you can see the nerve. Don't worry about trying to see anything else. Mrs. Krause, we're going to take a look at the back of your eye now. I'll ask you just to look straight ahead. I'm going to be stepping around to your right. Just keep looking straight ahead. You're doing great. I'm going to be getting pretty close. Mrs. Krause, now we're going to take a look at your other eye. Just keep looking straight ahead. You're doing a great job. Just a few things. You'll notice that when I was looking at her left eye, I actually ended up switching the ophthalmoscope to my left, and that's so that my nose doesn't touch hers or anything else on my face touch hers. That's inappropriate. And the other thing to remember is, again, if you can see the optic nerve, that's great. Just get used to trying to do that. The optic nerve, what you should look for in an abnormal nerve that has papilledema, which is the most common reason for this exam, is you'll notice that the margins of the nerve are not sharp, they're blurred, and you might notice that the vessels may seem a bit engorged. There may be some yellowish spots surrounding the nerve, or even little blots of blood surrounding the nerve. And that concludes our ophthalmology eye exam. It's been a lot of fun. I hope you guys have had fun as well. Please don't hesitate to find me or to join any of us in the ophthalmology department if you're at all interested. It's a wonderful specialty, wonderful career. Thank you so much for your attention.